So we're going to begin today with our next keynote speaker. Our keynote speaker is Russell Korobkin, the Richard C. Maxwell Professor of Law at UCLA School of Law, who is an expert in contracts, negotiation, and healthcare law. I think it is no exaggeration to say that in the law school, at least, he is the pioneer in behavioral economics insights applied to law. His work is incredibly highly cited on the subject. He's also a real mensch. I don't think you can say that about too many people, but about Russell, I think it's absolutely true. He's a world-renowned teacher, and he's taught all over the world, in Australia, in Germany, in the West Coast, and even here at Harvard Law School. And we're incredibly excited to have him here today to address us. So without further ado, I give you Russell Korobkin.
Thank you. It's really an honor to be asked to be here to speak to you today. Let me jump right in, because I'm going to try to cover a couple of different topics in my 20 minutes that I've been given. The fundamental problem, right, that I think unites us all and probably brings everyone that's in this room here for this conference is this, that efficient healthcare decisions are often too difficult for boundedly rational individuals to make optimally, right? That is, neoclassical economists assume that when we make choices, we're all maximizing our subjective expected utility given constraints, or put a slightly different way, that our revealed preferences, as determined by what we actually choose to do, matches our experienced utility or our predicted hedonic experience. I don't think it's a revelation that to people in this room, to most of us, that behavioral economics has given us some indication that this isn't always true. But what behavioral economics, I think, has done for us is it's provided a lot of insights into why it's true and how people go about making decisions in ways that are likely not to lead to optimal results. The million-dollar question, then, is what should policymakers do about this fact that individuals aren't always going to make optimal decisions even based on their own values and preferences? So yesterday, most of the discussion was focused around the book Nudge and the idea of libertarian paternalism, as Professor Sunstein calls it. Others have called it asymmetric paternalism or light paternalism. The idea to try to craft policy interventions that encourage actors to act in a way that policymakers think is in their best interest, right, while still allowing them the opportunity to choose otherwise, thus preserving freedom of choice and helping out in the case that policymakers are wrong and are nudging people incorrectly. So that's one approach, right? Nudging can help. It can be a partial solution to the problem of inefficient or lack of optimal choice by individuals, but it has several significant drawbacks, I think, that keep it from being a complete solution. Right? One is, and we heard a lot about this yesterday as well, that policymakers, of course, don't always know what's best for individuals. So even if you accept the premise of libertarian paternalism, oftentimes you have to scratch your head and say, which way do we want to nudge people? Right? We don't know. We might be nudging them in the wrong direction. And even though the concept of libertarian paternalism allows people the opportunity to choose otherwise, if nudges work, we're going to create, if we're nudging people in the wrong direction, we're going to create a lot of outcomes that are not optimal for the individual. Second, the best choice is often heterogeneous. That is, that people have different values and preferences. So even if we nudge a lot of people in the right direction, we'll probably be nudging a lot of people in the wrong direction at the same time. And the third problem is that the best choice for an individual is not always the best choice for society generally. So good for one, bad for all is one way to think about it. Okay, so while nudging is a partial solution, what I want to do this morning is suggest that the menu of non-coercive responses to the problems of bounded rationality be expanded. So when we think about choice architecture, I want to recommend that you think about not only the concept of libertarian paternalism that we heard so much about yesterday, but I want you to expand the menu to add two other options. The first is the one that I think policymakers should generally think about as the first line of defense to the problem of bounded rationality, which is, how can policymakers simplify the decision problem for individuals without pushing them in one direction or another, such that they're more likely to be able to make choices that are in their best interest? And then the second alternative that I'm going to talk about is the potential of nudging individuals, but not towards what policymakers think is best for the individual, but towards what policymakers think is socially optimal. And this is a concept that I've called libertarian welfarism, as an obvious contrast to the concept of libertarian paternalism. So I'm going to talk about each of these in turn. So problem number one. I don't have to tell anyone at this conference that healthcare costs are fast approaching a crisis point in this country. Not only do we spend a much higher percentage of GDP on healthcare than any other country in the world, but it's almost certainly the case that, at least in some instances, we are spending an inefficient amount of money on healthcare. That is, the marginal cost that we're paying is not justified by the marginal benefits that it's provided, although we don't always know when that's the case. So there are lots of reasons for this problem, and my short talk this morning is not the time to get into a lengthy discussion about why we pay too much for medical care. But what I do want to just suggest is that moral hazard is at least one significant source of this problem. It's not the only one, but it's one, as Professor Garber told us yesterday at noon. That is, when people have insurance and they don't have to pay the marginal cost of medical care, they're likely to, in many cases, overconsume. That is, consume more care than the marginal benefit of that care justifies. Technological innovation exacerbates this problem, right? The problem gets worse every year as technology gets better and better. Last year, the FDA approved a drug called Coercive for the treatment of some types of juvenile kidney disorder. Coercive costs $250,000 a year to provide. The standard treatment is called Cystagon. It costs $8,000 a year to provide. Coercive is better than Cystagon. The active ingredient is actually the same, but Coercive avoids a lot of very nasty side effects that Cystagon can cause. And also, Cystagon you have to take every 6 hours. So if you have a child with, that needs this medicine, you have to wake them up in the middle of the night every night of their life to give them this drug. Coercive doesn't have that problem, twice a day, 12 hours. Is it efficient to provide Coercive? It's better, but it costs $242,000 a year more. Hard to say, but at least raises the question of whether we're over-consuming relative to the optimum. Maybe yes, maybe no. Hard to say. The law prevents, interestingly, the law prevents insurance companies from mitigating this type of moral hazard problem. Everybody that has insurance that will cover Coercive is going to take it, right? No one's going to opt not to. In the 1990s, when managed care was at its height, insurance companies were more likely to refuse to cover treatments. But in today's environment, where most states have external review laws that are based totally on medical necessity and have and not on cost effectiveness or value at all, it's actually very hard for an insurance company to refuse to provide treatment that has some medical indication just because it's extremely expensive and may not be cost justified. So what do we do about this? Well, Dr. Garber mentioned the idea that's promoted by proponents of consumer-directed healthcare that we can reduce the moral hazard problem by getting more skin in the game. That is, higher co-payments, higher deductibles, make people spend more of their own money on their treatment. Then they'll have some incentive to balance costs and benefits. But I think the problem is obvious, that point-of-service medical care decision-making is just too difficult for most people to engage in an efficient way. That is, we know from research that if you increase copayments and deductibles, people will consume less care, but they seem to not, but the empirical evidence suggests that they're not very good at determining which care is cost justified and which care is not cost justified. So there are a number of reasons from behavioral economics that we could predict that people are not going to be very good at making these decisions. This is sort of 4 reasons that people often adopt simplified decision-making heuristics that are globally rational. They help people get through the day and make decisions and live their lives, but they often lead to choices that are not optimal. Decisions that are very complex, like medical decisions, often cause people to use simplifying decision-making heuristics. Decisions that are novel, most point-of-service medical decisions are novel. Not always true. There are chronic illnesses where people make the same decisions over and over, but generally speaking, most high-stakes medical decisions are novel. You get a lot of inconsistent presentation of information that can evoke different heuristics in decision-making. And the choices are heavily emotion-laden. That is, people are actually asked to trade off of attributes that they are hesitant to trade off, health being one big one. And that often causes people to adopt more simple decision-making strategies that will often lead to non-optimal results. Okay, so if having people have more skin in the game isn't a great way to deal with this problem, what about substituted decision-making? We could have insurance companies decide what care is cost justified for people, what's the efficient amount of medical treatment to provide, but this just trades one moral hazard problem for another. After your insurance company has your money, they have an incentive to provide as little care as possible, just like you have an incentive to consume as much care as possible. So that's not a great solution. Pay for performance is a big one these days. Let's have the concept here is let's have medical providers bear all the costs of care. Then let's pay them based on the benefits that they create. And so they'll have the incentive just to provide the optimal amount of care, no more, no less. But this creates a tremendous conflict of interest between doctor and patient. If you have medical insurance that promises you all medically necessary care, I assure you, you do not want a doctor that's trying to balance costs and benefits. You want a doctor that's going to provide all the beneficial care that is available. And doctors are going to have a substantial marketing problem getting patients if they deviate from that model. And I think they also are going to run into some potential legal liability as well. Okay, so what do we do? So my answer here that I've been pushing in a variety of places recently is simplify the choice for people. Don't try to nudge them in one way or another, but try to make the choice simpler so that they can better manage to make that choice. My proposal is called relative value health insurance. It's kind of simple. A government body rates treatments for different medical conditions based on the relative value of those treatments. So treatments for different conditions are rated on a scale of 1 to 10. 1 is very high value, a lot of benefit for the cost. 10 is very low value, has some benefit, but very high cost makes the small benefit questionable. So you can imagine this being done in a variety of different ways, but it would probably be done based on quality-adjusted life years per dollar, right? So if you had a treatment that provided a quality-adjusted life year for $10,000, that would probably get a 1 on the scale. You might imagine a quality-adjusted life year costing $500,000, that might get a 10 on the scale. So the government provides the ratings, and then this allows private insurers to sell coverage at different rating levels. So you might have in the market have an option of buying a policy that covers you to level 3, that is sort of the more cost-effective treatments, and that would of course be cheaper than a policy that covered you all the way down to level 9, the most effective treatment. So you might, for example, just say that Procyspi might be let's say a level 7 treatment. Right? It's certainly beneficial, but the marginal benefit might be somewhat low relative to the huge cost that it comes with it. And so whether that would be covered or not for a particular patient would depend on how deep an insurance policy the patient bought, whether they bought deep or shallow coverage. So the idea here, the reason this simplifies choice is that now with these ratings, customers, instead of having to make this point of service treatment decision that proponents of consumer-directed healthcare might want, instead patients at the point of purchasing insurance have a simpler decision problem. They have to trade off two attributes, the price of an insurance policy and the general level of depth of coverage that they'd be getting. It's not an easy decision to make, but it's a much more manageable decision where you're trying to trade off two attributes than when you're trying to make treatment decisions at the point of service. Okay, problem number two. So I'm going to switch gears here. So talk about a problem that we've heard a lot about yesterday, always comes up in talks about behavioral law and economics. 122,000 Americans are awaiting organ transplants right now. There aren't enough donors, right? We all know about this. We also know that one of perhaps the most famous of all default rules in behavioral economics is the famous paper by Johnson and Goldstein in Science, providing some pretty strong evidence that if we change from an opt-in default, where you're not a cadaveric organ donor if you don't opt in, to a presumed consent default, where you become a cadaveric organ donor unless you opt out, there's pretty decent evidence that would increase the rate of cadaveric organ donations quite substantially. Although David Orentlicher is going to present a paper later today that's going to question that conventional wisdom. So let's just, so I'll put that question to the side and just assume that this is true. Okay, here's the problem, right? So this is often described as an example of nudging, but it's a bad example for nudging because donating is almost certainly not optimal for the individual patient. You will be dead. You will not get a benefit out of being a cadaveric organ donor, yet you will bear some costs if you're a donor. They're probably small, but there's probably some non-zero chance that the medical team will be a little less give a little less effort to saving your life if you're a potential organ donor. It's probably not a huge risk, but there's some risk there. If we're going to be good libertarian paternalists, I think we would keep the default rule at opt-in, right? Because probably it's in the best interest of most people not to be a cadaveric organ donor. Just a minute on sort of a missing, what I consider a missing category problem. So we know about that if we want to get people to act in their own best interest, one approach is just to make them do it, right? That's coercive paternalism. So Sunstein and Thaler came along with this clever idea that they called libertarian paternalism, right? Which says, well, why don't we nudge people in the direction we think is best for them, but we won't force them. Now, on the other side of the chart, though, we could also coerce people to do what we think is best for society. Call that coercive welfarism. And the missing category is what I call libertarian welfarism. We could also use the techniques of nudging to nudge people to try to do what's in the best interest of society rather than what's in the best interest of their individual selves. So let's think about organ donation here. So the goal, right, of libertarian paternalism is to nudge actors to do what's in their own best interest. Libertarian welfarism is to nudge actors to maximize the value to third parties, do what's in society's best interest. So let's think of that most central of all nudging techniques, the use of default rules. Under libertarian paternalism, I think the proper default rule is no donation without active consent. But under libertarian welfarism, almost certainly the appropriate default rule is presumed consent, right? That's clearly, I think it would be very hard to argue that it's not in society's interest. It's not socially optimal to have more cadaveric organ donors. Very little cost to the people who are already dead, whose organs are being used, and an enormous benefit to the people whose lives can be saved. The implications here, I think, is that problem with libertarian paternalism is that it's normatively unsound for public policy makers to ignore externalities, both positive and negative, and that's really what libertarian paternalism tells us to do. I think this is because in some cases it won't matter. in a lot of cases, the externalities of private behavior are small enough that we don't really have to worry about the positive or negative externalities. And socially optimal and privately optimal solutions converge, but not always. And I think organ donation is a good example of that. And also there's the problem with libertarian paternalism that it's oftentimes difficult to tell what's best for an individual actor. On the other hand, for libertarian welfarism, there's a clear normative justification of maximizing social welfare, and oftentimes it's going to be clearer for public policymakers what's in society's best interest than what's in an individual actor's best interest. So while there's often going to be the problem of policymakers not knowing which way to try to guide people or which ways to try to nudge people, if the goal is social welfare maximization, oftentimes the appropriate direction for the nudging is going to be more clear than if the goal is just private welfare maximization. So the last point I'm going to make about this, and then we'll stop for questions, is that there is I think a clear reason why, if you're following the principle of libertarian paternalism, you want to keep the libertarian part, right? You want to be non-coercive. Because if policymakers are nudging people in the direction that's wrong for them, you want people to have the ability to opt out, right? To try to, when they know better than the policymakers. You might say, if our goal is welfare, social welfare, we're not worried about the welfare of the individual actor whose behavior is being affected by the policy. Why not just be coercive, right? Why keep the libertarian part? Why not just force everyone to be an organ donor? Right? If that's socially optimal, we'll just make a rule that everyone's organs are up for donation after they die. But I think there are a couple reasons why non-coercive welfarism can be preferable in many cases to coercive welfarism. The first is that freedom of choice enhances social welfare. Right? So autonomy is good. Holding everything else equal, autonomy is a good thing, so having more of it creates more social welfare. And if you compare a presumed consent default for organ donation versus a coercive rule that everyone will be an organ donor, you get value about giving everyone a choice versus giving no one a choice. And the other reason is that when you have collective action problems where you don't need everyone to be part of the solution, but you need some people to be part of the solution, it's often the case that libertarian welfarism will allow you to create the collective good at the lowest possible cost. So when you think of organ donation, if we allow people to opt out, then we'll have enough organs, most likely, right? We don't need everyone to be an organ donor. We just need more people than we have now. And the people for whom it is very high cost to be an organ donor will be able to opt out, and they will opt out. The people, for example, maybe with religious convictions that would be inappropriate, they can opt out. And then the people who are maybe not organ donors under an opt-in system because they're mildly uncomfortable with the idea, but the cost of them being an organ donor is still relatively low, those are the people that will be affected by the presumed consent default, and inertia will cause them to just go along with the default and become an organ donor. So we have a situation where we separate the high-cost providers of the social good from the low-cost providers and let the low-cost providers actually do the providing. Okay, so two ideas, as I said, to expand the menu, right? Simplifying choice and nudging people towards social welfare. I'll stop there and take questions.
So you can stay put, but we'll have people at the microphones.
David Ornetlicker, Indiana. Thank you. I will explain this afternoon why you are right on presumed consent to organ donation.
Oh, great. Fabulous.
But my question is, the one thing I would want to modify your, coercive versus libertarian welfarism is the reality that we're more willing to be socially minded when everybody else is being socially minded. And if we have it, make it if people can opt out, your example, have a religious exemption, but if everybody could opt out of organ donation, then, well, if they're opting out, why should I do it? And so I wouldn't want to lose that benefit of, having everybody bear the burden of some social welfare goal.
Yeah, so I think I'm just trying to there describe some of the benefits of libertarian welfarism versus coercive welfarism. But I take your point that in some cases we might want, if we have a welfarist approach to policy, right, in some cases the right tool will be to be coercive. So I didn't mean to suggest that we would to rule out the possibility of coercion. I was just trying to explain there are some reasons why, at least in some cases, even if our goal is social welfare rather than individual welfare, we might want to nudge people rather than force people.
Good morning. Chris Robertson from University of Arizona. Thinking about the organ problem, it strikes me that it's important to think about the larger background issues of justice that are presented by the case and how that might then justify different policy interventions. So if it turns out that the organ system is fundamentally unfair because it allows people to, say, benefit from the pool of organs without contributing to it, allows them to sort of free ride, then we might think that offering an incentive to those that nonetheless do agree to donate or share their organs could be justifiable.
Yeah.
And if that goes through, then all of a sudden individuals do have a benefit for being in the pool, and maybe it makes sense to flip the default rule to an opt-out system, because as long as you're in it, then you have priority access to receive organs, as is done in Israel.
Yeah. So good point. Again, what I'm trying to do here with this talk is really not to suggest this is the best policy for organ donation. That's really just sort of a placeholder example about how the theory might work. What you're suggesting, Chris, is absolutely right. Is that one way to solve social welfare problems or collective action problems is just to change the incentive system. Right, so we could let people let people go to the head of the line if they're organ donors. That's one way. We could make people pay a fine if they're not organ donors. That would be another way. But that's kind of I guess I would say that incentives are the standard way that we think about solving these kind of problems. And I'm just trying to again here give two more options on the list of possible things to consider, not to preclude incentives.
Let me take the moderator's privilege and ask a question, which is the relationship between libertarian welfarism and paternalism. So one possibility would be whatever is justified to do under libertarian paternalism, you can do slightly less under libertarian welfarism because it is essentially not in the favor of the person whom you're seeking to manipulate. And I was kind of curious whether you have a sense of the muscularity of the interventions that are justified, whether you would agree with that proposition or not.
Oh, I'm not. So I'm sorry. Explain, Glenn. Why would the
well, the idea is that at least with libertarian paternalism, even
Yeah.
if I'm manipulating you in that way, kind of trancing on your autonomy in some way, even in this minimal way,
Yeah.
I'm doing it in a way that aligns with your interests. Whereas in libertarian welfarism, the fact that it's not libertarian paternalism tells me by necessity it's not aligned with your interests; it's aligned with someone else's interest.
Mm-hmm. So I think that's very interesting. I think it just depends on your philosophical view of paternalism versus welfarism, right? I don't think so. It seems to me if you're more queasy about social welfare as a goal of government policy rather than individual welfare, then you might be more hesitant to use those interventions. But I don't think it follows necessarily from the theory or the concept that you would necessarily use interventions with less muscularity under one versus the other.
Matt Lawrence from the Petrie-Flom Center. Just had a question about the relative value health insurance.
Yep.
Let's say we're kind of convinced and we're trying to operationalize it.
Yep.
At what level of kind of generality do you imagine the rating agency specifying treatments? Would it be MRI or MRI for someone with a concussion or MRI for someone with a concussion and history of concussions and so on? And then what I'm just kind of imagining is that the insurer would still have an incentive to say that a particular treatment in a particular context was lower, So for you, this chemotherapy is a 4, and the doctor would say, no, it's a 5 because he's still our advocate. And you would I don't know that it's a bad thing, and maybe this is the sort of dispute we should be having, but you'd get disputes about, whether or not, the particular symptoms, the particular case. That sort of thing.
So great question. I mean, this is, I had to, so, I have two papers about this particular topic, right? And I just put them up here. Like, if you want to learn more details, please consult. I have two papers that came out just in the last couple months about this. But the, sort of the basic, there are a lot of problems and a lot of obstacles to the idea. Here, in theory, where I would like to see it go. Should be that the list of the rating should be as specific to conditions as possible. So based on your condition, your diagnosed condition as a patient, here are the whole range of interventions that might be offered, and each one is rated for that condition, right? And to the extent that we had information, obviously we're not going to have it in many cases, but to the extent we had information that's also said that someone with this condition that has the following other health problems, or doesn't have the following other health problems, that a certain treatment would be more effective or less effective, that should play into the rating system as well. They should be as specific as we can get given the information, and it shouldn't be then up to the insurance company or the doctor. This would all be housed in a website that had all this information, and so we would look at that and say whether it's a 4 or a 6 for you based on your particular situation. Consumers, of course, when they're asked to make the choice of what level of health care to buy, are not going to be reading this entire database, right, and understanding, but they will have a general sense of the trade-off between health care and other goods and services that they could get by saving their health insurance money and buying other things. And they will know that whatever level of care they buy, they will be getting the most cost-effective things, and they will be foregoing the least cost-effective things at whatever the level is.
So we're slightly over, but let me get the next panel to come up as we take one last question so we can double dip. So if you're on the next panel, please come up here while Professor Moncrief asks her question.
I now feel like amazing pressure to make this question better than it actually is.
It
But,
better
Best
be really,
question ever.
I know,
really good,
right?
Abby, really good.
So for purposes of the video, I guess I'll introduce myself again, even though Glenn just said it. I'm Abby Moncrief. I'm a professor at BU. And my question is actually kind of related to Matt's, which makes this all the more embarrassing that I'm the last question. But I want to push back also on the existence of uncertainty in medicine and how that plays into our ability ever to create a relative value scale for certain kinds of treatments. So there are definitely areas where we know a lot about what kinds of treatments are going to work and how well, particularly when we know what the diagnosis is, but there's so much uncertainty in what the diagnosis is in the first instance, and at that point it's not clear that we're going to be able to figure out anything about relative value. And there's, as you said, I think there's sort of a cultural feeling of Americans that more healthcare is better, and that patients are going to want to push in the direction of, I want as many diagnostic tests as you can possibly provide. But that's not necessarily a cultural inevitability, and I wonder whether we need to get some purchase on pushing back against that as well, to say, like, more healthcare is not always better, and if we need a sort of more systemic change than just providing information. And then relatedly, and I'm sorry to take up more time, I'm wondering also whether whether this is really behavioral at all versus just information forcing. And I am struggling in a sort of grand sense in figuring out what behavioral is as opposed to other kinds of incentive setting. But but this seems like pure information forcing to me, so I'm curious.
Yeah. So right. So it's information provision. That's right. So it's behavioral in the sense that it's a response to a behavioral problem, right? The behavioral problem is that individuals are not going to be good at making optimal treatment decisions at the point of service, even if they have more skin in the game. That's the behavioral problem. The solution in this case, what I'm suggesting, is that rather than try to, on the back end, take advantage of or play on decision-making heuristics that people use. Instead, this is a situation where simplifying the decision might be the best solution to the behavioral problem. And simplifying the decision in this case is collapsing a lot of complicated information into essentially one number, which is the depth of coverage that your insurance policy would provide. So as to your first point, I'm just going to kind of let that stand and say I agree, right, that there are relative value health insurance might not be a complete answer to the problem of overconsumption of care, and it's a difficult operationally, it's a difficult answer to provide, even if it's not a complete answer. All true, and I think I'll just have to leave to another day the discussion of the merits of that particular policy versus others, and just use it today as an example of a policy intervention that would simplify choice rather than trying to nudge people in one direction or another.